patients. So let's start with a 21-year-old that is a patient of mine, soccer player. She's a collegiate athlete that had syncope or passing out while she was in soccer practice. So to give you a little bit more detail, she was running sprints with her soccer team and turned around at the end of the soccer field to run down to the other end, sprinting, and collapsed. She was approached by her soccer coach. Her soccer coach appropriately recognized that she was not breathing. He checked for a pulse and there was none. So he appropriately called for an AED. And fortunately, by the time the AED arrived, this patient was starting to wake up and regain consciousness. So there was no need to use the AED. The patient shown here went to an ED, an emergency room, and was seen and had this EKG. And unfortunately was told that this EKG was normal. She went back to participate in sports, and her coach said, "What on earth are you doing here? Again, is there a doctor's letter that says that you can play?" And sent her home to get another opinion from a physician. Again, this is the coach that said this. And through convoluted means, they ended up in our clinic, and we diagnosed what we'll get to here in a second. So this is her EKG. And for those of you that don't read EKGs, this is an opportunity for us to not pull out our calipers and squint and measure, because to a trained eye, this is really an egregiously long QT interval at 540 milliseconds, that the diagnosis here is pretty clear in the context of a passing out spell during exercise. So this patient, we were highly suspicious, had long QT syndrome. So what to do now? The clinical questions for us, and certainly the way that we have to frame this conversation with our patient is, well, is this long QT syndrome? And if it is, what type is it? And how can we be sure about that? We had our suspicions for sure, and we'll get to why we had those suspicions. How do we treat this? Is this a situation where medical therapy is sufficient, or is this a scenario where a defibrillator is more appropriate? What she really cares about as a collegiate athlete on a scholarship, the only thing she really cared about is, when can I play? Like, hey, this is cute. I see moms pointing to children, I suspect, here on the video chat. This is cute, thank you very much, but when can I play soccer again? And obviously we're very sensitive to that too, and we want nothing more for that patient to play again, of course, as long as it's safe. And then who else should we worry about? This is the person that presented in the family, but everybody has a mom and dad, and a lot of people have brothers and sisters. We can't stop there, and we got to dig a little bit deeper. So knowing that long QT syndrome is an ion channel problem, let's get into the history of the ion channel. This will be one slide, and we're not going to bore you with this, but I thought this is interesting. So the timeline here is I think, an eye-opener. In 1889, years and years and years ago, the first recorded channelopathic death was discovered by Javrell Lang Nielsen. Again, more than 100 years ago, when we first realized that maybe ion channels, maybe arrhythmias, are what are the culprits to sudden death in some patients. In the 1960s, so it took years till ion channels resurfaced again, but in the 1960s was the first description of long QT syndrome by Romano and Ward. And several years after that, the first Brugada syndrome patient was identified, another ion channel problem. The first genetic correlation of long QT syndrome was made by Michael Keating in 1991. 2000, sort of the opposite cousin of long QT syndrome is short QT syndrome. That was discovered. This is 20 years ago. In the time frame of medicine, that's not very long ago. So this gives you an idea of how new a lot of this ion channel business is. And since the mid 90s till now, what we're doing is honing in on what genetic data translates to the clinical world. So what we see in in the laboratory, what we see with gene testing, and how that relates to what we see at the bedside and what we see clinically with our patients. It is impossible to start a conversation about long QT syndrome without talking about the EKG and the ion channels. So let's dive into this. I would say of all the things that probably is the most elusive to our families when we explain long QT syndrome, it's this piece of it. So I do want to spend some time explaining to everybody what we're actually dealing with. So the first is to start with the conduction system. What we do in clinic is I will typically draw on that paper that our patients sit on. I call it the butcher paper. I draw on the butcher paper a diagram that looks like this, that shows the construct of how the heart beats. And let's walk through that here using the laser pointer. Shows it in the top chamber of the heart, and the heart has 4 chambers. Top chambers are called the atria. The bottom chambers, the pumping chambers, are called the ventricles. And what we see here in this cartoon is that the impulse initiates here in the top chamber. Once that impulse travels down to the middle of the heart, it causes that top chamber to squeeze. And then the impulse rests for a second here in the middle, allows the bottom chamber to fill with blood. Then that impulse gets sent down to the bottom chamber, then the bottom chamber squeezes. What's important in the context of long QT syndrome is the amount of time it takes, and we'll show this several times over again, for the bottom chamber to squeeze, and then you see the relaxation of the bottom chamber. This kind of frizzing of the electricity there in red is the bottom chamber recharging again. So the key here is in long QT syndrome, how long it takes for the bottom chamber to squeeze and then get ready again for the next beat. So this is all orchestrated in a very complex way on the molecular level. So if we had microscopes that were very powerful, we can see inside muscle cells, inside heart muscle cells, we would find that embedded in the membranes of these cells are these things called ion channels, these gates that allow things like potassium, that's drawn here, calcium, again, potassium and sodium, here's sodium. All of these ion channels manage different types of ions and create this perfect environment of this dynamic flow inside and outside of the heart muscle cell as the heart muscle cell squeezes and relaxes again. So the perfect orchestration of all of this is reliant on these ion channels working flawlessly. So in other words, if these ion channels are working like they're supposed to, the heart muscle cells squeeze and they relax again in the way that we expect them to. Any perturbation in that, any damage, any misconstruction of these ion channels causes all of that balance and all of that orchestration to go awry. What that can lead to, as we'll see here in a minute, is arrhythmias. But all of these ion channels, if they are broken, can cause a smattering of ion channel diseases and heart rhythm diseases. Long QT syndrome, of course, being one of them. This translates into something called the action potential, but more importantly, what we see in the ion channel level and what we see clinically is very different. What we see as clinicians is an EKG that shows us these tracings. We'll dissect this very soon, but these tracings really tell us what the ion channels are doing. Ultimately, the EKG is really a surrogate, is sort of a next in line for what goes on upstream, which is what's happening in the ion channel realm. The QT interval is drawn on EKG paper like this. And again, I don't want to get into the details here, but looking at this from a 40-foot view, what's important on this slide is to understand how we measure things like the QT interval and what we're actually measuring. So when an EKG comes out and your doctor, your heart rhythm doctor is looking at that EKG, what they're wanting to know in the context of long QT syndrome is what the QT interval is. And what we do when we measure the QT interval is we measure the start of this complex called the QRS complex to the end of this hump called the T wave. Let's not get into that and instead think about this globally. What are we really measuring here? What we're measuring in the start of the QRS is the initiation of the heart squeezing, like we saw on that slide prior. From the onset of the heart squeezing to the end of the T wave is the end of the heart relaxing again. So again, we're measuring the QT interval, which is the amount of time it takes the heart to squeeze and relax again. When we look at this on EKG paper, we can measure this pretty precisely as an interval involving milliseconds. So a fraction of a second is what this turns out to be. To hopefully not complicate matters further, but to shed a little bit more light on the clinical exchange unit that we use, the conversations that we have are in QTC intervals rather than QT intervals. The QTC simply, and not to get too deep into this, is basically just a way of us correcting that interval so that we can say, based on a heart rate, this is what your QT interval means. It really just provides some more clinical context for what we see and measure on an EKG. But the QTC is going to be the number that we focus the most attention to, that translates into risk, translates into whether this is abnormal or not. The QTC is really the crux of the matter here. And I just wanted to show everybody where that number actually comes from, and it's from this formula. So what do we mean by QT prolongation, and how does this all translate? So when we look at an EKG, which is this blue guy here, when ion channels are working normally and potassium is being, for example, pumped in and out of the heart muscle cell like it should, the QT interval is what the QT interval is supposed to be. If we say damage one of these ion channels and cause it to not work properly, in long QT syndrome, that's because the DNA, the genetic code that makes these ion channels, isn't quite right, and the ion channels end up being imprinted not quite right. What that causes is, if the ion channels don't work quite right, is the QT interval can prolong. So this is, again, looking at what happens on the molecular level to what happens on the clinical level, what we see when we see patients in the hospital and in clinic on an EKG, is that the QT interval is going to be long. So we're going to move away from the science now and get a little bit more into the reality of it all. And first talk about the epidemiology of long QT syndrome. So what is long QT syndrome? Who gets long QT syndrome? How common is it? Long QT syndrome is a leading cause of autopsy negative sudden death. What that means is, if somebody experiences sudden death and their autopsy is totally normal, then long QT syndrome is up there on the list of things that could possibly cause a cardiac arrest. It happens in the US about 1,000 times a year, at least that we know of. There is likely a lot more patients that suffer from this, and we just don't know that they have it. It's mostly in young children in terms of when they present, and the hallmark presentation, syncope is our medical code word for passing out. And what we say is that there's no prodrome. Let me translate this. What happens in patients with long QT syndrome when they have a passing out spell is there's no warning sign beforehand. They don't feel unwell. They typically don't feel dizzy or lightheaded. They pass out and they wake up, and they oftentimes don't know what happened prior. And that when we hear that as doctors, we say, uh-oh, there must be a problem going on here. Let me contrast that to the passing out spells that most people have. The more common type of passing out is called vasovagal syncope. That occurs when people see blood, for example, or get their blood drawn, or stand up real fast and get kind of dizzy and pass out. That's the boring, who cares, this is not a problem passing out. That has nothing to do with long QT syndrome. The long QT syndrome passing out is very, very different for reasons that we'll discuss. The arrhythmia that we see looks like this. And the reason why I wanted to show you all this is because this has a name in the medical community called torsade des points. And it's a French name, which means twisting of the points. Oftentimes, when we're evaluating patients with arrhythmia disorders, this is the specific arrhythmia that we're looking for, and this is the specific arrhythmia that affects patients with long QT syndrome. The reason why it's important to recognize this is because when patients have this arrhythmia, they pass out. They don't get chest pain. They typically don't get dizzy or lightheaded. They typically don't feel like their heart's racing. They usually just lose consciousness. And again, the reason why is because this arrhythmia typically doesn't allow for patients to feel much. They just end up passing out. So what is long? This is often something that comes up in our long QT patient community. Patients and families will often ask, what is my QTC today? And is that long? And what's normal? The answer is there's a lot of grayness here. And let me just explain why. This is a paper that came out from Dr. Ackerman's group that shows the normal patient population that they see at the Mayo Clinic. Here, it looks like a bell-shaped curve where the average QTC of a normal person is about 400 milliseconds. So that's where most people live. If you look at the height of people in the United States of America, in male and female, you're going to see that it looks like a bell-shaped curve too. Most people, most males are 5'10". Most females, I think, are like 5'5". So most of the time, you're going to expect people to fall sort of somewhere in that framework. Whereas if we look at the long QT syndrome population at the Mayo Clinic, that bell curve is shifted over to the right, expectedly so, where the QT interval now for a long QT patient on average is going to be somewhere in the 490 range rather than in the 400 range. But what we can see here in the green is this overlap zone where the normal patients and the long QT patients kind of mix here in the middle, where if you take a patient with a QTC of, let's say, 460, it's hard to say whether they belong to the normal group or the long QT group. So our job as clinicians is to say, well, long QT syndrome goes much further than just an EKG. It's not just that makes you have long QT syndrome. It is a family history. It is symptoms. It is what happens when you act. All of these other things go into the equation, so that for us, sometimes it can be quite a challenge to say whether somebody's normal or whether they really do have what we call long QT syndrome. One important study that we know of, I won't go into this in detail, but what this study did by Peter Schwartz, also a very active SADS member, looked at a bunch of EKGs from about 45,000 babies that were born in Italy through a screening program that they did. And what they found was the QTC intervals kind of looked like a sort of a pyramid where the majority of everybody, all these babies, had a QTC that was less than 440. Normal, not concerning. A smattering, about 2% were less than 450. Then you get above the 460, where only a very small fraction of those patients had QT intervals that were that long. And they decided to do gene testing in all of these patients that had QTC intervals that were above 460. What they found is that if you're above 460 and below 470, there was about a 30% chance that you had long QT syndrome based on gene testing. Whereas if you were above 470, there was a just under 50% chance that you had long QT syndrome. So what they did is they used some math and they said, well, the estimated prevalence of long QT syndrome then in the white patients in this Italian study was about 1 in 2,500. And I think to the layperson, 1 in 2,500 sounds like it's not that common. But if you put this into the context of a general population, 1 in 2,500 is a lot of people, especially for a pediatric heart rhythm provider where we're kind of seeing things that are labeled as rare. I don't think long QT syndrome really is that rare. And we'll find out here in a minute that long QT syndrome type 1 is a big chunk of the long QT syndrome. So all of you out there that have long QT syndrome, as you probably are well aware of, you're not alone, because it is very, very common to have this. Speaking of long QT syndrome type 1, I want to talk a little bit about what long QT syndrome types there are. So the long QT syndrome type 1 patients follow a specific set of rules in a lot of ways, whereas the long QT2 and the long QT3 can follow a different set of rules. And I think it's important to understand that. So long QT syndrome, as we talked about, was first discovered in 1995 in Michael Keating's lab. And since then, they've discovered lots of other genotypes. But the first three, 1, 2, and 3, are the most common and make up the overwhelming majority of long QT syndrome. About 75% of all long QT syndrome is the 1s or the 2s or the 3s. The remaining genotypes, genotypes are 5%, 4, 5, 6, 7, 8, so on and so forth, are only 5% of the long QT syndrome. And then there's 20% that we know have long QT syndrome because they show every sign and symptom of it, though we do gene testing and they're gene negative. And that's 20% of the population with long QT syndrome. So what is long QT syndrome type 1? I'm just going to put a box over this. Let's focus on the long QT1 group. It has about a 35% frequency among all long QT syndrome patients. Compare that to long QT2, 30%, long QT3, 10%. So long QT1 is the most common type of long QT syndrome. It affects the KCNQ1 gene. That's just the gene name for what long QT syndrome type 1 is. Affects this iron current. I'm going to skip these guys here. The most common trigger, this is an important concept to understand here, and we'll hammer this out in the upcoming minutes, is that the events are triggered typically by exercise and sympathetic tone. Exercise, running, being active, exerting yourself. Those are the things that typically cause a long QT syndrome type 1 patient to have an event. Whereas in long QT2, auditory stimuli, alarm clocks, for example, emotional startle, around Halloween, we always talk about the haunted house. Things like that can affect the long QT2 patient. And in long QT3, it can be sleep, which is a very challenging concept here for our families, because ultimately, how do you avoid that? But I think in the long QT1 group, there's lots of things that we can do to change this metric. We'll get to that here. The patients that are characteristically higher at risk are males in their pre-adolescent years. And the response to beta blockade here gets a 3+, meaning that the patients with long QT1 have the most robust response to beta blockers. Beta blockers work the best in them more than any other long QT syndrome out there. So I would say, I tell our patients this with long QT syndrome, if I had long QT syndrome and I had to choose which long QT syndrome to have, it would definitely be long QT syndrome type 1. So for those of you that have long QT syndrome type 1, congratulations, you picked the right one.
Peter, I have a question from Dean.
Yeah.
What do you mean by sympathetic tone?
Great question. I should have explained that. So what we mean by sympathetic tone is anything that increases your adrenaline, that increases your revving up in your body. And things that do that are exercise and excitement. Anything that falls into those categories can be a trigger.
Okay. And follow-up question from Ilana. What exercise is the most common trigger? Can't auditory stimuli or emotion, etc., still be possible triggers, but less common?
Yeah, it's a great question. So we're going to get a little bit into that in the upcoming slides. And if I don't totally address that question, then remind me and I'm happy to address it afterward. Okay. That's a great question.
All right.
Thanks, Marcia.
Sure.
So to that question, what triggers are we telling our long QT1 patients to avoid? This gets kind of tricky. So full disclosure, I'm a pediatrician. So we talk in cartoons, right? This is how we discuss things with our patients. And I drew a picture, or I copied a cartoon of two young kids swimming intentionally. Swimming is a different beast. And to the question that was just asked, what type of sports are worse than others? There's something special about swimming. We're going to talk about this upcoming, but swimming tends to have this profound response in patients where they don't even have to necessarily swim. They can just jump in a pool of water, and that alone can be a trigger. So we're a little cognizant of that. And I'll tell you practically what that translates into. Years ago, we would just say, don't swim. Years ago, we would say, don't play sports. We've changed that for reasons which we'll explain. Exercise testing, I know that all of you, well, I presume that many of you in the audience that have long QT syndrome type 1 have been asked to run on a treadmill or exercise on a bike, and I'm sure you hate it. And I want to explain to you why we do this. I see young patients leaning into the microphone here. You're on bated breath, waiting to hear what we're going to say about this. Why do you torture us so often? Here is the reason. There's really several. The first is that there is critical information that we can glean from an exercise test that help us better manage patients with long QT syndrome. At the beginning, when we don't know whether you have long QT syndrome or not, the exercise test can provide us with some objective information to tell us whether your ion channels work normally or not. So we just talked about the cases of EKGs where we can't really tell in an EKG when it's in that borderline gray zone, whether somebody has long QT syndrome or not. We have to have adjunctive testing, other things that are objective that tell us whether somebody is normal or not normal. And the exercise test can provide that. So just showing you briefly, we have pretty good understanding of how control normal patients behave and how our patients with long QT syndrome type 1 behave. That's this green line here. Their QTC gets pretty profoundly abnormal when they exercise and when they recover from exercise. And it's very useful when we don't know what the diagnosis is to be able to show what kind of pattern we find in the long QT patient when they exercise. That's one very important piece of information. The other important piece of information is we want to make sure that patients aren't having arrhythmias when they exercise. This is very rare, but if we were to see an arrhythmia in somebody on an exercise test, we would say, well, our treatment strategy here is failing us. We need to do more for you to keep you safe. The other important concept here to understand is that the exercise test can tell us whether we are doing enough with our beta blockade. So let me explain that a little bit further. If I ask one of you to exercise and your heart rate as, let's say, a 16-year-old patient got up to 215 beats a minute, I'd say that's pretty fast. It's almost like you're not on a beta blocker at all. And that can be the cause of one of two things. One is they're not on a beta blocker, or they're not taking their beta blocker. And two is the beta blocker dose is just not high enough to give us the effect that we want. So this can help us titrate that medical therapy to know we're actually affecting change. We're seeing that your QT, or that your maximum heart rate is lower than we would expect it to be for somebody of your age. So this can be not only helpful diagnostically in the beginning, but also helpful prognostically in letting us know as a child grows or an adult patient whether their medical treatment strategy is effective.
Peter, I have a question also from Lanny. What is considered borderline? I was told 480 to 490 was borderline.
It all depends on where on this, let me pull back here, where on this graph we're comfortable being. So sorry to move back here rapidly. But this is the key, right? If we choose a cutoff that is way out here, let's say my cutoff in the Cleveland Clinic is 500 milliseconds. So if you're over 500 milliseconds, I think you're abnormal. You could justify that, but you have to understand the pros and the cons of picking a number like that. So if I choose my cutoff to be 500, if anybody I see is over 500, there's a pretty good chance they have long QT syndrome. The problem is there are people that are 480 and 470 that clearly have long QT syndrome that fall in this graph that you're going to be missing. So the question isn't what is the cutoff? The question is, if I choose X as a cutoff, who am I going to be capturing and who am I going to be missing as a result? The contrary is true. If I choose 440 as a cutoff, I'm going to be taking a huge chunk of normal people and saying that they're abnormal. So 440 is probably not the right answer. 500 is probably not the right answer. At the Cleveland Clinic, we usually use about 470 as kind of a flag of being abnormal. That doesn't mean you have long QT syndrome. That just means that we got to dig a little bit deeper. A 470 is a hello, let's meet you and get to know one another, not you have long QT syndrome and here's our treatment strategy, if that makes sense. What I want to emphasize here is the EKG is such a thin layer of the evaluation that we don't want to put too much credit on an EKG that's normal or abnormal. As many of you probably know, you've had EKGs that are perfectly normal. That doesn't mean you don't have long QT syndrome. It just means that your EKG happened to be normal that day. And that's the complexity of this a little bit. It can be very confusing, but that education piece, I think, is really important. We want to de-emphasize how important that number really is in many of our patients. It can fluctuate quite a bit. I hope that answered that question. So looking at, again, Dr. Peter Schwartz paper from years ago, showing us what types of triggers there are. And of course, we're going to focus on long QT1. The majority of patients that had events had it with exercise, though there are some patients, to the question we heard earlier, that have events with emotional stimulation or even at sleep, during sleep or at rest. But the majority, of course, have, in long QT1, have exertional or exercise-induced triggers. Now for sports participation. All right, so this is the old Bethesda guidelines. And for those of you that don't know this, years ago, this is all we had. So if you had long QT syndrome, we would look at this chart and it would say, if you have long QT syndrome type 1, you're in this corner in terms of sports participation restrictions. You can play billiards, bowling, cricket, curling, golf, riflery. I know this so well because this is what we used to tell our patients all the time. And it made me cringe every single time we did it because I knew that something was not right about these guidelines. We fought these guidelines. We went against the guidelines many a times after talking to patients and having a conversation, what we call patient autonomy and self-determination. Patients would say, I hear you, but I don't care. I'm going to do what I want to do regardless of what you say. And we didn't say you can't. We just said, okay, well, let's figure out how to make that safe. Where we've been from there to then, understanding what our children's reaction is we don't want to alienate anybody. We don't want this happening. So let me move away from that slide. What we want to do is say, well, what data do we have that shows us that makes sense? Or what data do we have that shows us that it doesn't make sense? What we did institutionally when I was in Philadelphia is we gathered all of our long QT syndrome patients, and a lot of them were already exercising despite those guidelines. And we said, well, let's study this. What are we finding out? And to summarize, we had 755 patient years of athletic participation, no events during sports in all of those long QT patients, more than 100 of them. One long QT2 patient had an arrhythmia while being infected with influenza, not playing sports, not exercising. And one patient had an ICD therapy while running in their backyard, still not participating in sports in an organized way. So what Dr. Ackerman and a group of very astute colleagues of his is they said, well, let's look at this data from our group, from the Mayo Clinic group, which is very similar to the results that we had. And they said, are we doing what we're supposed to be doing? Let's revise those Bethesda guidelines and give our families and our providers a little bit more wiggle room. There is an evolution here that's important to talk about. I'm going to focus on what's going on down here. The European Society of Cardiology in 2005 said, if you have long QT syndrome, you can't do anything. Not even the class 1A, not the curling, crickets, golf, bowling, riflery, you can't do anything. If you have an ICD, you can't do anything. The Bethesda, the one that we just showed, said, well, you can do those class 1A sports, curling, crickets, golf, bowling, riflery. And then the task force 10 said, wait a minute, is this really what we should be telling our families? And they changed this to no restriction, except for long QT1 swimmers. We'll get to that in a second. And if you have an ICD, you really need to talk to an expert. What task force 10 allowed us to do is it really said, talk to your managing provider, your heart rhythm doctor specialist about what you can and can't do. And you all can come up with a decision on your own. Now that we've been empowered with this, it's really been a huge game changer in the conversations that we have with our patients. Now, if you're a long QT patient, they say you can do anything you want except for competitive swimming. This is what I wanted to talk about here with swimming. I have long QT patients that are competitive swimmers. The reason why I have long QT patients that are competitive swimmers is because if you're a competitive swimmer in a pool, in a gym that has an AED, that's much different and much safer, in my opinion, than swimming. I live in Cleveland, swimming in Lake Erie, unsupervised, where you can't see the bottom of the water. In a circumstance like that, where the water's murky, somebody's swimming by themselves without a life vest on, that is a troublesome scenario for me. So my only line in the sand for long QT syndrome type 1 is you can't do that. You can't be in open water unsupervised. If you want to be in a pool in a park, there's an AED there, knock yourself out. If you want to be a competitive swimmer and there's an AED there, knock yourself out. In most circumstances, of course, it's individualized and these are decisions that we make together, but that's mostly the case. Treatment, cortisone therapy is this lovely medication that I'm sure many of you know, Nadolol. This happens to be the 20 milligram tablet. It is serrated here, so you can chop it in half. Beta blocker therapy in long QT1 and long QT2, not all beta blockers are created equal. We have an institutional predilection for using Nadolol. Propranolol, at least in this study, has been shown to be effective. Metoprolol seems to have a lot more breakthrough. And that's one of the reasons why we like Nadolol. We prefer it. Medication avoidance is another cornerstone of therapy. The SADS Foundation has links to this. You can look at Credible Meds, qtdrugs.org. All of these lead you to the final common pathway, which is this lovely website where you can type in a medication and see if it is, in fact, contraindicated in long QT syndrome. Who gets defibrillators? I'm not going to read this to you, but essentially what this says is you get a defibrillator if you've had a resuscitated cardiac arrest. And that seems pretty obvious. You get a defibrillator if you are on a beta blocker and you end up having an event on a beta blocker. That's pretty much it. So if your Uncle Joe had a cardiac arrest and he had long QT syndrome type 1 and you have the same gene as Uncle Joe, that doesn't mean that you get a defibrillator too. And the reasons why essentially are that we know that genes don't penetrate the same in family members, meaning that one person with one gene may behave very differently than another family member with that same exact gene. So family history is not one of the variables that goes into decision-making about getting a defibrillator or about risk in general in long QT syndrome. So now back to our patient, the 21-year-old soccer player. What did we do with her? We ended up doing gene testing for a patient that had exertional syncope. And what we found was that she had long QT syndrome type 1, exactly what we were suspecting she would have. We put her on Nadolol. She didn't have symptoms for an entire year, and we allowed her to participate in her senior year of soccer, which she very much appreciated. And we screened all of her relatives. It turns out that she has 4 siblings. 3 of them have that same KCNQ1 gene, that same long QT1 gene, and all of them are under our care. This brings me to my last and final point, is the value of an inherited arrhythmia clinic. So the construct that we have here is similar to that in other institutions, but essentially the framework is the same. You have pediatric heart rhythm doctors, you have adult heart rhythm doctors, you have geneticists, and you have our genetic counselors, all working together for the treatment strategy of our long QT patients. This is a group effort. It involves participation of the entire family oftentimes. And I'll tell you as a clinician, without that family framework, it is really hard to do what we need to do. So your doctors have to be prepared to be able to tackle that family as sort of a unit. Key takeaways here, long QT syndrome is an ion channel problem. Long QT syndrome type 1 is the most common. The triggers are sports and exertion. Treatment is Nadolol. The prognosis is excellent. And care should be patient and family-based for all the reasons that we talked about. These three characters are my lovely daughters. Thank you all so much for your attention. That's all I had to say, and I want to open this up to questions now.
Thank you very much, Peter. We do have some questions that folks have posted. And let me go back here. Carol asked, how often should an exercise test be done?
I don't want to get your doctors in trouble, so I'm a little hesitant to give you an answer to that. However, I'll tell you what we do here. I think there is sort of the obligatory exercise test, typically that starts usually at the onset of diagnosis or right before the diagnosis for diagnostic reasons. We don't know whether you have long QT syndrome. We're trying to figure it out. The exercise test can help with that. So that's kind of the obligatory first one. We usually will initiate therapy, get patients on a therapeutic dose of Nadolol, which we do typically over like a month, even longer than that, just to kind of sneak it into the system so a patient can tolerate it well. Once we're on that full dose, particularly in the athlete, we'll repeat the exercise test then to make sure that we're therapeutic, to make sure that the effect of the beta blocker is really something that we can objectively identify. If that's where we are, things look okay, and they're tolerating their beta blocker, and it looks like it's doing what it needs to do, then we usually don't repeat the exercise test for at least another year. So no more than a year that we repeat them.
Okay, thank you, Peter. Dean asks, what determines which beta blocker is used?
We really have, again, an institutional favoritism towards Nadolol for the reasons that we discussed. Propranolol is well, as far as we know, is equally effective in long QT1. I think those two medications, if you're a long QT patient of mine and you have long QT type 1, you're going to be most likely on Nadolol, maybe on propranolol. Those are basically the two medications I would use exclusively in that patient population.
Mm-hmm. Okay. Ileana asks a similar question. My mother has long QTS1 and had an episode, had an ICD put in 15 years ago, but is not on beta blockers. Should she be?
I don't want to get your mother in trouble. The answer is clearly yes. And the reason why is because beta blockers in long QT syndrome type 1 are so effective that I almost consider it curative. They work so well that it's almost like you don't have long QT syndrome in a patient that can be on a full dose. So in a patient with long QT syndrome, if we're not putting them on a beta blocker, I feel like we're selling them a little short of really a true full-blown medical therapy. An ICD is not preventative therapy. It is secondary therapy. In other words, it's not going to prevent you from having a heart rhythm problem or a cardiac arrest. It's just going to treat it afterwards. ICDs are machines, and any machine, any computerized machine in particular, has a small predilection, but has certainly a possibility of failure. So we cannot rely on just that as saying monotherapy, just an ICD, we don't need anything else. I believe so strongly in beta blocker therapy that I really do think that should be sort of the baseline for everybody. Even in the patients that say they don't tolerate it, I hear this all the time. We usually can come up with a way to get them on a beta blocker dose that is effective, that doesn't cause side effects.
Okay. What if you're unable to take betas due to a low heart rate?
That is a challenge, and I would say very few of our patients have a heart rate that is so low that we can't give them a beta blocker. Oftentimes patients will ask, how low can my heart rate be? No number. I don't look at the number. I don't care if your heart rate's 30. That's not the final determinant of whether you can be on a beta blocker. It really is side effect titration. So if your heart rate's 30, then I would say, well, we'll put you on a really small dose. And on a really small dose, we might be able to get away with getting some beta blocker in your system without giving you side effects of having a low heart rate. And that's more important than what the heart rate is whether you have side effects from having a heart rate that's low. Dizziness, low blood pressure, that sort of thing.
Mm-hmm. Does the length of the QTC interval indicate the severity of long QT or the likeliness of an event?
Yeah, I didn't get into this, and that's a perfectly valid point. The length of the QTC does translate into risk. Typically, our line in the sand is about 550. If you're more than 550, then your risk data shows is higher of having an event.
Okay. How are you treating your QT1 patients with asthma?
We still use beta blockers, and it depends. If they are an asthmatic, that is a frequent flyer to emergency departments, for example, and they can't tolerate a beta blocker for the life of them, then we have to come up with a plan B. For the most part, just like the low heart rate patients that we talked about, for the most part, there is some degree of beta blockade that you can introduce to an asthmatic without giving them an asthma exacerbation. So there usually is a way.
Okay. Ileana asks again, I understand exercise is the most common trigger, but could long QT1 patients still be cautious with alarm clocks, haunted houses, auditory kind of stimuli?
We don't see those triggers as the predominant. I would say my focus would be more so on the exercise triggers. There is overlap though, as that figure that we showed by Dr. Schwartz, 75% of patients have exercise as a stimulus, though that doesn't mean that no other stimulus can be possible. The other 25% obviously had triggers that were non-exercise related. So, caution is certainly prudent.
Okay, thank you. Tara asks, her family has the R231C variant. A paper came out calling it a disease-linked super trafficking of the K channel. What does that mean?
So Tara, I'm going to have to do some homework on that. I'm not familiar with that paper off the top of my head. I can provide you with my contact information, or Marcia, the SADS people can. Feel free to email me and I will take a look at that paper and let you know.
Okay, thank you. Let's see. Cynthia says, I'm now 58 years old. Let's see, it just jumped up there. Diagnosed.
Lorelai.
Pardon me?
There.
Oh, hold on a second. I'm now 58 years old, diagnosed in 2008. Does the aging process have an effect on my long QTS? I've been on Toprol since 2008. I see you recommend another medicine. So Cynthia.
So Cynthia, I would very simply say there are two things I want to hit on. First is, as you get older, and what we know is past the age of 40 is one of those lines in the sand. If you are past the age of 40 and your QTC is normal or near normal, your risk of a life-threatening event is almost that of the general population, meaning that even though you have long QT syndrome, your risk of having an event is quite low. If you're over 40 and your QTC is long, most providers would likely recommend beta blocker therapy for you. And I understand that you're on Toprol. I would simply ask you to talk to your prescribing physician about that decision and say, is there another beta blocker that you think would be better for me, and have that open and honest conversation with them.
Okay, thank you. What factors influence beta blocker dosage?
So in our pediatric population, there's a lot of them. In our pediatric population, the biggest factor is size and weight. So the formula for us is very simple. The unit of measure that we use for weight is kilograms, not pounds. So we find out what their weight is in kilograms, and we basically dose it 1-to-1. So for example, if a child is 20 kilograms, which is like 45 pounds or so, we want to dose them in 20 milligrams of Nadolol. So it's usually 1-to-1. What we talked about before is, if I see a patient for the first time, particularly a teenager, and let's say that teenager weighs 50 kilos, we want to put them on 50 milligrams of Nadolol. If I start them on 50 milligrams of Nadolol that first day I meet them, they will never come back. So what we've learned is you got to sneak it into the system over time and give their bodies a chance to acclimate to that medication. And once it's been several weeks and sometimes even longer than that, we find that you can get somebody to tolerate 50 milligrams, a therapeutic dose, usually across the board with few exceptions.
These are great questions. They keep coming. Should all people with long QT1 be on beta blockers? From Mary Ellen.
If there's not a really good reason to not be on a beta blocker, yes.
Okay, Sandy asks, with medications that may prolong QT interval, how common is that, and does that prolongation that occurs with meds have to be as long as the syndrome, and how likely is that prolongation to cause syncope?
Can you read that question again? I just want
Yeah, let me try this again. With medications that may prolong QT interval, how common is it? And does that prolongation that occurs with meds have to be as long as I'm not sure I understand it either. Have to be as long as the syndrome, and how likely is that prolongation to cause syncope?
Yeah, I think I understand the question. So
Okay.
How I'll respond to that is this way. I think the QT prolongation with meds is something that can happen to anybody. So in other words, you could be a normal person with a normal ion channel without long QT syndrome. And if I gave myself, for example, enough azithromycin, my QT interval will prolong. Not because my ion channels don't work right or because I have long QT syndrome, but because that is a normal response for anybody, is that they prolong. The danger if you have long QT syndrome already is that you're already starting off long. It's going to prolong your QT interval even more. And oftentimes that's the kind of push that takes somebody that's never had a symptom before into I'm all of a sudden a symptomatic patient. So the question about does it prolong it further and will it prolong it more than a long QT syndrome patient? If you don't have long QT syndrome, the medication will prolong your QT interval. If you have long QT syndrome, the medication will prolong your QT interval even more so than it does in somebody that doesn't have long QT syndrome. I hope that answers the question.
So Sandy, let us know if it does not. We can come back. Brianne asks, should the LCSD surgery be something to consider for someone as a primary treatment for long QT1, even if they tolerate betas? Or should that only be considered if beta blockers are not an option?
That's a tougher question. In our clinical experience, in my personal opinion, that is a personalized conversation you should have with your physician. The bottom line, though, is that denervation therapy has risk. I think the risk is small, but it is surgery. So with any surgery, there's risk of infection, there's risk of bleeding, and then of course there's risk of permanent damage to part of the nervous system that you need. Those risks are not profound and not life-threatening, and it really is a matter of, like we always talk about in medicine, the risk-benefit. How bad is it that you're taking the beta blocker versus the risk of a denervation therapy? We go to denervation therapy in patients that have breakthrough on their beta blocker medication, have intolerance because of depression, exacerbation, that sort of thing.
Okay, thank you. Courtney has a long one here, but here's the story. One of my sisters and I have been genetically and clinically confirmed long QT1. However, we have another sister who was not genetically confirmed. She was told by one doctor that she had borderline prolonged QT and by another that she had acquired prolonged QT. Would you say she falls in the 20% genetically elusive category? And should she be treated with betas?
That's a tough one. So the questions to ask, I think, in this situation is, are we sure that the long QT syndrome that's identified in the family is the culprit? In other words, sometimes what we find is there is a long QT syndrome gene that lurks in the family, but the people that have QT prolongation don't have that gene, and the opposite, the people that are totally normal do have that gene. So is that gene really the player? The other question here is, in the acquired situation, we'd have to know a lot more about that. What is her baseline QT? How long did it get with the influence of medication? That person may not have an ion channel problem, may behave like a normal person would in that circumstance. It really just kind of depends on how much they got and in what context. Were their electrolytes normal? There's a lot that goes into it.
Okay, thank you. Dean asked, my 6-month-old daughter was diagnosed with long QT1. You said that swimming is okay in pools with AEDs and supervision. Does that same also count with small babies and toddlers? Are there any exceptions for babies and toddlers?
The good news is that you're never going to have a baby or toddler swimming on their own. So you're automatically going to be swimming with that baby or toddler. So there's a person attached to that baby at all times in an obligatory way. So that's good. I would say, for the families that have pools in their backyard kind of thing and the baby's swimming, the probability of a baby having an event, period, in long QT syndrome type 1 is very, very low. Usually events happen when they get into the school age, if not older. So for a baby to have something like that, it's pretty unusual. I would say if a baby is supervised and, whether or not there's an AED there can play into it, but I wouldn't have any particular precautions in that scenario with a baby.
Okay. Kaja asks, did we understand you right that the risk of a fatal event is low as long as an AED is close enough?
Yes. So I would answer this two ways. The risk of having a life-threatening arrhythmia is low in the context of having long QT syndrome type 1 and being on a beta blocker. The risk of having a fatal event is low if you have an arrhythmia and there's an AED there, and there are people that know how to use the AED and know how to perform CPR. I'll say it another way, the probability of a good outcome in that scenario is really high. Probability of full recovery if somebody's getting attended to right away.
Mm-hmm. Okay. Sarah asks, what is the likelihood that a person could eventually stop using beta blockers? My 15-year-old son was diagnosed last year via genetic testing, completely asymptomatic. Once he's out of the danger zone, could he get off beta blockers?
As of 2021, I guess it depends on his EKG in some ways. If he's an asymptomatic patient that lives through the childhood years where the peak incidence of long QT syndrome is a little higher, then the likelihood that he can come off a beta blocker at some point is pretty high. The when is the gray, right? So that 40-year line in the sand is something that we've seen in literature. That we may find that 40 is really 30 or really 25. We don't know that quite yet, but I have a feeling it's probably younger than 40, where we find that we can get patients off beta blockers if they're asymptomatic and if their EKG is normal, maybe a little bit earlier than that. But that's not set in stone. That's not backed by literature. We really don't know. I think most clinicians would probably give you different answers about that.
Mm-hmm. Okay, Emma asks, I was newly diagnosed and on a beta blocker. Should I ask my EP to do a stress exercise test at our second appointment?
So I think this should be the last question, or maybe one more. We're getting overtime.
Mm-hmm. We only have a few more.
I was hoping that you would save me, Alice, from answering that question, but I guess not. We have to be diplomatic about this, of course. I think it's fair to ask your electrophysiology doctor, what do you think about the utility of doing an exercise test? Do you think that would help with a diagnosis or help with understanding whether my beta blocker is working? That's how I would frame it to that person. And perhaps they have a very good answer. Oh, we're not going to do the exercise test because we're going to do this instead. I don't know, but I think it's worth that challenge.
Okay. We may just do.
Okay, last one.
Last question. Let's see.
Pick the best one you want to do, Marcia, because you're going up and down.
That's
forever.
what I'm trying to do here.
Pick a really hard one, right?
I think I'm going to save the pregnancy question for when we do a pregnancy topic, because I don't know that, Peter, you want to answer that one.
I'd be happy to.
Oh, okay. Well, let me read it. It's from Ileana. What's the most recent updates regarding pregnancy? Is pregnancy, labor, or postpartum dangerous for long QT1 patients?
I love this. So we
right.
just gathered our own institutional data on the pregnancy question, and hopefully this is going to come out soon. But what we found, and again, this is a sample size that involves one institution, certainly not across the board. But what we know about long QT syndrome in pregnancy is a bunch of things. One is that in long QT syndrome type 1, pregnancy or the postpartum period isn't considered a vulnerable trigger. It is in long QT syndrome type 2, which is a different beast. The second is that in patients that are treated through pregnancy and after pregnancy, the probability of an event is quite low. The approach here, whether they need to have C-sections and all this business, there's debate about that. Most electrophysiologists would say a normal birthing plan is perfectly acceptable. No alterations in how we approach the birthing process.
Okay.
I don't know if the thing is some OBs won't agree with that, obviously, but most electrophysiologists, when it comes to taking care of the mom, feel very comfortable having a mother go through labor that has long QT syndrome.
Okay. She had a part 2 of that related. Is there testing in vivo and in vitro with IVF?
Yeah, there is. And most institutions don't do that. I would say there's some risk involved in testing in vivo preterm or pre-birth. We usually will test postpartum. And the reasons why is it's very rare that a long QT syndrome patient at birth is going to require therapy. It's not unheard of, but it's not common. So for the most part, we're not instituting therapy until we have a pretty good sense as to whether they actually have long QT syndrome anyways, which can sometimes wait. So we usually do our testing after they're born.
Very good. Okay, I'd like to thank Dr. Peter Aziz for his time today, and you're getting a lot of comments that people really enjoyed the presentation. So thank you very much. And what we'll do is we'll have you and Alice go off into a breakout room, and we'll have everyone else stay, and I'll have a few questions for you as patients and parents, and we can get to know one another a little bit for the next maybe 15 to 20 minutes or so.